Treatment for CBP is with the use of antimicrobial agents, and this therapy needs to be initiated for the length of 4 to 6 weeks or longer in order for the antimicrobial agents to have an effect and to penetrate into the prostate tissue. Even despite this length of therapy, the infection is likely to recur. So the first line of treatment for both the initial and recurrent episodes is with the fluoroquinolone. If this is not appropriate for the patient, an adequate alternative is trimethoprim sulfamethoxazole, known as Bactrim or Bactrim DS. Other agents that have the ability to penetrate into the prostate tissue include tetracyclines and macrolides. These are not usually considered, though, as the first line of treatment. So the reason this penetration into the prostate tissue is so difficult is due to the barrier between the microcirculation and the prostate gland stroma. This prevents passive diffusion from taking place. So this only allows a non-protein bound lisophilic antimicrobial agent to reach a therapeutic level within the gland. Prostatic fluid also possesses a problem in that it has a low pH, which allows alkaline antibiotics such as the fluoroquinolone or sulfonamide to achieve a high enough concentration to have an antimicrobial effect can be difficult. So of note is that when the prostate tissue is inflamed, it has been noted that the antibiotic penetration can occur more readily, yet the first line of choice for this type of treatment is with the drug that has the optimal penetration. So for this patient, due to the initial diagnosis of CBP, Mr. Weber will begin a treatment course of ciprofloxacin, or Cipro, 500 milligrams PO every 12 hours in combination with Levaquin, 500 milligrams PO daily for a period of 6 weeks. Studies have shown men that complete an antibiotic course for 4 weeks or longer have a 6-month clinical cure rate of approximately 60 to 70%. So we're going to monitor the patient for adverse effects that are related to fluoroquinolones, and very important to ensure that the treatment course is completed. Some of the side effects or adverse events that we're looking out for include gastritis. He's actually at a little bit more susceptible rates and risk due to his current treatment for a stomach ulcer. We're going to look at hepatotoxicity and monitor his lab values. We're going to assess for any complaints of headache, dizziness, mood changes, sleep disturbances, peripheral neuropathy, seizure, prolonged QT interval, dysglycemia, phototoxicity, and hypersensitivity reactions. So if the patient doesn't respond well to this treatment with the fluoroquinolone, the next line of treatment will be the trimethoprim or the Bactrim, and that'll be 160 milligrams PO twice daily, and the sulfamethoxazole, 800 milligrams PO twice daily. This combination is often given longer than 6 weeks. However, relapse or recurrence happen within months to several years of follow-up in approximately 67% of men.